Good day, and on behalf of the Morehouse School of Medicine Prevention Research Center, we welcome you to part 2 of our Prevention Works webinar series. Additionally, we invite you to connect with us via social media using hashtag PreventionWorks. Here at the Morehouse School of Medicine Prevention Research Center, our mission is to advance scientific knowledge in the field of prevention in African American and other minority communities, and to disseminate new information and strategies of prevention. At the MSM-PRC, we strongly hold to the applied definition of community-based research, which is dynamic, works to establish partnerships between communities and research entities, is focused on prevention, tailor-made, is designed to implement interventions that are ethnically and culturally focused, and is established to develop more effective health policies to advance health equity. I now present to you today's webinar entitled HPV Vaccine, What You Need to Know, presented by Dr. Melissa Kottke. In compliance with ACCME guidelines, Dr. Kottke has no financial nor other relationships with the manufacturers of any commercial service discussed in this educational activity. The objectives for today's webinar are to characterize HPV prevalence and incidence among marginalized populations, to evaluate the effectiveness of HPV vaccinations, and to analyze the best practices for normalizing HPV vaccination among all populations.
Spectacular. Thank you so much for the introduction and for letting me be here today. I am very excited to spend a bit of time with y'all talking about HPV vaccination with the lens that HPV vaccination is cancer prevention. And hopefully by the end of our time together today, we may be able to consider the question that I've put at the bottom of this slide, which is, can we eliminate HPV-associated cancers in one generation? To start us out, I think it's important that everybody, I know that the folks that are on this call today have a really wide background and exposure to working with vaccination and working with HPV. So I'd like to kind of start at the beginning and make sure that we're all on the same page about HPV and HPV vaccination. So the first question is, what is human papillomavirus, or HPV? HPV, the first thing to take away from this talk is HPV is ubiquitous. There's a lot of it. There are more than 200 types of virus strains under the umbrella of HPV. They largely fall into two buckets: cutaneous, meaning a virus that infects the skin, and anogenital, meaning a virus that infects areas in the genital tract. The human papillomavirus is not only very common, but is spread with skin-to-skin contact, both the cutaneous type and the anogenital type. So if we're thinking about cutaneous type and you think about a wart that's just a common wart that's on your hand, or a plantar's wart, that's all from the same family of what we're talking about here today. The anogenital types, there are actually about 40 different types of viruses that can be transmitted in the genital tract. Now, the majority of these are sexually transmitted, but I think it's very important for us to understand that because this is skin-to-skin contact, sexual intercourse is not required to transmit human papillomavirus. And I'm going to pause, and I'm just going to make sure that that statement percolates just a little bit with everybody. Sexual intercourse itself is not required in order to transmit the HPV virus. Indeed, HPV is exceptionally common, so much so that many people look at it as a marker of any type of sexual activity. Over the one's lifespan, you can see over here on the right, I think I have a little arrow. Let's see if this works. Yes, what you can see here, this is an infographic that I downloaded from the CDC. Some people estimate that 80% of folks of all people in the US, will get an HPV infection at some point in their life. This is a conservative estimate. Others will estimate even higher than that, 85 to 90%, or even higher yet. This is actually one of my very favorite titles that I've ever seen on any medical journal that describes why we need to care about HPV and some of how the framing and our recommendations for HPV vaccination will be. So this paper came out about 2 years ago entitled "Penis is Not Required: A Systematic Review of the Potential for HPV Horizontal Transmission that is Non-Sexual and Does Not Require Penile Penetration." The study identified, it was a systematic review that identified a bunch of other studies finding that human papillomavirus was detected in the genital tract of female virgins, so those who had never had intercourse, with prevalences anywhere between 0 and 50%. HPV transmission HPV can be transmitted from hands to genitals, genitals to hands. This has been reported in both genders, in heterosexual couples, and HPV fomites have even been found on other surfaces. And so the key takeaway here is that human papillomavirus is everywhere and is exceptionally common. And the majority of people, the majority of us on this call today, have either already been infected or can anticipate that we will be infected at some point in our life. And what exactly is an HPV infection? The thing about it is that most people who get infected with HPV don't know that they've been infected with HPV. The majority are pretty asymptomatic. And because our immune systems are awesome, the majority of us clear this infection without us doing anything over the course of 2 years. However, there are a subset of folks that cannot clear the infection, and those are the folks that are at risk for some of the outcomes of HPV disease that we're going to talk about over the next couple of slides. What you see here, let me move this guy. This green arrow here is HPV prevalence. And so what you can see is that the peak prevalence of HPV in the United States is for folks who are between 15 and 25 years old. What you can see here is we look at as the prevalence goes on for age, it peaks here in the mid-20s and then declines, but doesn't actually go away through the rest of the life course. There is a path of, I'm actually going to go on to the next slide and talk about this. This you can see here is a pictogram of human cells in the genital tract. This one is specifically in the cervix. And it shows how an HPV infection can actually lead to cancer and invasive disease. So HPV, if it's given an opportunity, will infect cells in the genital tract. So the cervix, the vagina, the vulva, the penis, the anus. It can also infect similar cells in the oropharynx, so in the mouth, the tongue, the back of the throat. When HPV virus gets an opportunity to get into one of the cells, again, your body is going to try to get rid of the virus on its own, and the vast majority of the time that works. And so folks can live here in this, like, I have a bit of an HPV infection, but my body is fighting it for many months and not know that anything is going on and be totally fine. Again, about 90% of them are going to get rid of the infection and go back to a normal state. However, about 10% of folks, their bodies won't be able to fight the infection. And the infection can lead to a precursor lesion, which is changing from normal to slightly abnormal. For those people, for cervical cancer, we're actually lucky because there are ways that we can detect that through pap smears and kind of other screening modalities. However, there are some folks who go from HPV infection to the precursor lesions and then onto invasive lesions or onto cancer types of outcomes. And it's this here that we're really trying to avoid. When we look at HPV-related outcomes, there are a couple of really important things to know. HPV is associated with 6 cancers. They are penile, vaginal, vulvar, anal, oropharynx, and cervical cancers. When you look at the pyramid to the left, what's a key takeaway here, these are by the numbers of U.S. cancers that are attributed to human papillomavirus each year. And what you can see is that first, both males and females are affected by HPV-related cancers and other HPV-related diseases. The one that is most important from a public health perspective is cervical cancer. Nearly all cervical cancers are associated with HPV infection. And when folks first started looking at the HPV vaccine, indeed it was the goals to prevent cervical cancer that underrode most of this. However, what we've identified is that there are so many other HPV-related diseases that can be impacted by the vaccine. So in addition to our 6 different cancers that are related to HPV, we have 2 other key HPV-related health outcomes that vaccination can impact. The first is juvenile onset respiratory papillomatosis. This is where an infant actually acquires human papillomavirus through the birthing process from a mother who may be infected at the time. That's a benign condition, but it can have a pretty high morbidity associated with it, and that impacts both infant males and infant females. The other HPV-related outcome that is not cancerous but is problematic for many are genital warts. So genital warts affect both males and females. Indeed, about 1% of the U.S. population is affected by genital warts at any given time. And again, although these are benign, they're associated with both physical and psychological morbidity and have a relatively high rate of treatment failure. So the key takeaway from this slide is one of the questions that we get from folks is, why do both males and females require vaccination? And indeed, what are these outcomes that we're trying to avoid? So we are trying to avoid cancers in both males and females and other HPV-related diseases in both males and females. I'd like to show some of the HPV-related associated cancers and break it out by race, ethnicity, and gender as well. And so this is the age-adjusted rate here. All races, in the solid bars are women, the hashed bars here are for males, and you can see about 13.6 per 100,000 people will be diagnosed with an HPV-related cancer. And then when we go across the graph here, you can see that this really impacts everybody. There are some differences between race and ethnic groups, but by and large, HPV is an equal opportunity infected or virus. Let's talk a little bit about the vaccine itself. And up here in the blue, these are, well, a cartoon of an HPV virus. And for those of us on the call who are not immunologists, I'm going to tell you that I am not an immunologist. There are little attachment points and points where around the outside of a virus, the body, when they see it, so if a virus has an opportunity to get inside, if you will, the body has cells that will recognize things that aren't from the body, and it will generally try to attack it or to try to employ some of its defense mechanisms. And so HPV vaccination, when it was being developed now about 20 years ago, they said, you know what, we want to take just part of the protein. So part of this, what they call a virus-like protein, this outer shell. We're going to take that. We're not going to take any of the gene inside of the virus. We're not going to take anything that could actually cause an infection, but we're going to basically take its lookalike, its doppelganger, and we're going to put that into this vaccine solution. And if you administer that protein, basically it causes the body to make these antibodies. Antibodies are I think of them as like little hats that will go to this blue guy and say, oh, I've seen you. I know what you are. And the antibody covers up this vaccine, and it encourages the body to phagocyte it, or to kind of eat it, so that the virus can't actually infect any cells. It can't do like what the picture before was for the cervix. So vaccines basically expose the body to something that kind of looks like the bad guy, if you will, causes the body to build up its sense of immunity, build up its protection, so that if the body ever does get exposed to the bad guy, then the body already has already practiced, if you will, and already has a strong response to get rid of that virus. And so the HPV vaccine was a huge breakthrough. It causes antibodies, it prevents infection, and most importantly, it prevents cancer. We think about the vaccine. I want to talk a little bit about best practices with regards to who should get the vaccine and when and why. So the HPV vaccine is best delivered to both male and female preteens at 11 to 12 years of age. And there are a couple of really important reasons for why that recommendation has been made. First, the immune response for a young person is just better. It's stronger. When a young person is exposed to a vaccine, their immune response, their ability to make antibodies is about twice as high as someone who is, say, between 15 and 25. So exposing a young person to a vaccine means that their body is going to do a better job and be able to keep them more protected in the future. That's one of the critical reasons that HPV vaccination should occur when a person is younger. The next is that HPV vaccination undoubtedly works better prior to any HPV exposure at all. So the likelihood of an 11 to 12-year-old having had any kind of sexual contact, even just skin-to-skin contact, is quite low. And so there's very little little risk that that young person has been exposed to any type of HPV, which will make the vaccine work better for them ultimately. And this is very, very important. The dosing schedule here has changed over the past couple of years. I'm going to give a little bit of an overview about HPV vaccination in the US. But in the past couple of years, we have only had a 9-valent vaccine. What that means is that that one shot protects the person who's getting that shot from 9 of the different, roughly 200 types that I mentioned earlier. And those HPV types are listed here in this slide. There are a couple that are very important. 16 and 18 are the HPV types that are responsible for 70% of cervical cancers in the US and around the world. So that is actually where the HPV vaccination started. They're like, well, let's focus on the biggest bang for our buck. And then when we've had so much success with how effective the HPV vaccine is, they added on several other of these types that expand it such that the 9-valent vaccine really prevents about almost 90% of cervical cancers and about 90% plus of genital warts as well. The schedule for HPV vaccination, because of how robust a young person's immune response is, as I mentioned on the previous slide, this is actually a relatively new recommendation that if you have a person who's under the age of 15 initiating the HPV vaccination series, they can achieve full coverage with just 2 shots. And as somebody who takes care of teens every day in my clinical practice, I know that that's something that's very exciting to them. So on the vaccination schedule that you would see if you go to the American Academy of Pediatrics or the CDC, the recommendation is to have 2 shots if, again, that first one is prior to the 15th birthday. And they should be 6 to 12 months, sorry about that typo, apart, with at least 5 months in between. If a person does not initiate prior to their 15th birthday, then the recommendation is for people to receive 3 shots. And this is the way this used to be done, again, until a couple of years ago, where you would get one shot, you would get your next shot roughly 2 months later, and then a third shot 6 months later to complete the series. So current recommendations for a 3-shot series are for those who are 15 and over, those who are immune compromised, so somebody who is HIV positive or had a transplant or any other key health conditions that make a person immune compromised would require or do best with a 3-shot series. Now, current recommendations are that, again, the best age is 11 to 12, but we can start vaccination as young as 9 in both males and females. In females, coverage is recommended up through age 26, and in males through age 21, and then those males who are between the ages of 22 and 26. The Advisory Council on Immunization Practices, really recommend what they call permissive use between the ages of 22 and 26 for men. So those who are immune compromised, men who have sex with men, or basically somebody who wants it, should be given access to the vaccine. The only challenge is that for those who want the vaccination but don't fall necessarily under those recommendations by the ACIP, their insurance may not cover that. And so it's not a health concern, it's honestly just a financial concern. Some of you may have recently noticed that the FDA has approved this vaccine for use up through the ages of 45, which will be really interesting to see what happens. The ACIP has not weighed in on that yet. I think that there are some cost-benefit issues with making the recommendation broadly. So again, maybe an insurance coverage issue in the interim. But the vaccine is safe in those settings. It just should probably be utilized in a shared decision-making practice with the patient, looking at their risks. Next, and very importantly, I want everybody on the call, and what we should share with others is that the HPV vaccine is exceptionally safe. It was first approved in 2006 and had a lot of safety testing. A lot of safety testing prior to that. And since its approval, over 80 million doses have been given. You can see that these have been given across the world. Listed in this in that graphic here are just some of the national and international organizations that support HPV vaccination. Importantly, one of the, well, let's talk about safety. There was a review committee that was looking at safety concerns associated with the vaccine and found 2. They are injection site soreness or infection, and then the other is syncope or passing out. Syncope is a possible side effect of any vaccination. And so the recommendation to ensure that there isn't injury associated with that is to have somebody be observed or kind of stationary and sitting for about 15 minutes after getting a shot. One of the questions that gets asked related to HPV vaccination safety and the mode of its transmission is whether or not the vaccine and having the vaccine has any association with change in sexual activity. And there have been at least 7 studies that have looked at this from several different angles. And we have found, or nobody have found associations with any change in sexual activity with having the vaccine. But how good does it work? The vaccine is very effective. I'm going to present, these are clinical trial data. And so these estimates are based off of large international randomized trials of both the quadrivalent, back when it just had 4 of the types of HPV, and now the 9-valent, including over 30,000 people. So this is very robust. And what they were looking at was not just can we prevent cancer, but can we prevent those precursors of cancer? Can we prevent when things start to look a little bit funny? And they found a 97 to 100% prevention of these precursor lesions in people who had never been exposed to HPV. So again, to people who had, who kind of got in that sweet spot that we talked about. There still was a benefit for somebody who had been exposed to HPV. It just wasn't as robust. Other studies have looked at males for this. So one study of males who have sex with men found the quadrivalent vaccine to impact the precursors to anal cancer, and found a 78% reduction in those who had never had HPV exposure, and again, still a 50% reduction to those who had and had not been exposed. Vaccine efficacy has been looking at prevention of oral HPV infection and found to be about a 93% reduction. I think it's really important. We can feel very good about this, and we know that there are also population data that go along with this to say we're just seeing less cervical dysplasia. We're seeing less. I will say that in the past 5 years, I've been operating a teen clinic now for over a decade, and I used to have treatment for genital warts, like a little bit of trichloroacidic acid, or TCA, trichloroacidic acid. We would just have that everywhere because we needed it, because we had young people who came in with genital warts so frequently. And I don't remember the last time I used it. I don't even know where the clinic keeps it anymore, just as my personal vignette about what I've seen with regards to vaccination efficacy. One of the things that's really important to keep in mind, however, is that whether or not somebody has received the vaccine, they should still be following all of the screening recommendations. Currently, our screening recommendations for cervical cancer don't change at all whether or not vaccination has been received. This is a chart that shows HPV vaccination rates compared to the vaccines that are also recommended for young people who are 11 to 12 years old. I mean, when I look at the data, to me, they're very compelling that this is something that it can impact health, wellness, and is a cancer preventative. Unfortunately, when we look at the data, it looks as though our vaccination rate is trailing. So up here you have Tdap, so tetanus, diphtheria, and pertussis vaccination is due at 11 to 12. Here you have the meningococcal vaccine. It's also due at the same time. And that is one that requires a second dose. And so you can see that that is a little bit less, but still quite high and robust. Down here, unfortunately, is where we start to see what's happening with HPV vaccination. So it's definitely lower. Thank you. It's definitely lower than the other two that are given, at the very same visit even. HPV vaccination rates vary pretty substantially by geography. And that you can see there's just the map of the United States. And I think our goals should be greater than 60%. We should actually try to be up near 80% like we are with some of the other vaccinations. But we certainly still have over a handful of states that aren't even achieving 40% yet. There are some differences in HPV vaccination rates by other population factors as well. So again, the total of the US is just right under that 50% mark is kind of the coverage in US adolescents. There are differences between people by socioeconomic status. So being below the poverty level, young people are actually more likely to receive HPV vaccination. That may be because HPV vaccination is covered by Vaccines for Children. So for people who are uninsured, people who are Medicaid eligible, and certain ethnic populations would have access to coverage, so payment wouldn't have to be a barrier. There is a rural-urban difference here, with urban young people being more likely to receive the vaccination, and then teen girls are more likely than teen boys. Why is this gap? There's been a lot of research done on this particular issue, and this is a study that asked parents about what were the reasons you didn't get this vaccination for your young people. And there have been some changes. People have been, really trying to work on this between 2010 and 2016, 2010 and 2016. We still have work to do, but some of the big concerns that parents describe is a concern over safety. About 20% of them thought across the board, males, females, and over time, that this wasn't something that was necessary, that they didn't know about it, that their provider didn't give them a recommendation for it. There's an assumption of that their youngster isn't sexually active. And then for parents of boys, there was, but it's actually getting much better, an uncertainty about whether or not this was even necessary for young men. Part of the reason why it's important for boys to be getting this is not just for their own future protection, but also this concept of herd immunity. So if everybody has vaccination against this virus, then it really can't spread anywhere, right? Like even if one person gets it because they weren't vaccinated, they can't give it to anyone else because of the other people being vaccinated, be they male or female partners. And so herd immunity is an important reason. It helps both boys and it helps girls. And so what are some strategies that we can all do to help increase the HPV vaccination rates? There are some clear strategies for providers. Having provider messaging be succinct and in support of an HPV vaccination is really important. Having a provider say, I think this is important. It can prevent a common infection. It can prevent cancer. It has lasting benefits, and this is safe, can make a very big difference. Some of the recommendations is to frame HPV vaccination as this is one of the vaccines that happen at 11 to 12. This is my recommendation for you. Our vaccines are the Tdap, the HPV, and the meningococcus. I recommend them all for patients of this age. Do you have any questions for me? Young people and their parents can be concerned about this idea of getting 3 shots at a time. And we can validate that. Like nobody really wants to have 3 shots all at one time. But we as providers should not present the importance of HPV vaccination to be any different than that of the other vaccines that they're getting that day. Indeed, thinking about the likelihood that someone is going to get meningitis, there's about 1,000 cases of meningitis a year in the United States. But there's about 26,000 HPV-related cancers, not just HPV infections, every year in the United States. So I guess the question is, there isn't a question. That's actually just information. What are some strategies for non-provider settings? And I think this is really important for a lot of folks on the call. I think the first thing to do is to address young people's and parents' questions. And in my opinion, this is something that community-based participatory research has had the most impact and has really been super useful in lots of different settings with regards to helping to move the HPV vaccination conversation forward. In different, specifically folks in near the border have had focus group discussions with Latina women trying to understand their perceptions and understanding of and priorities about HPV vaccination. Folks at Meharry and Vanderbilt have created content specifically for African American and Latina women. Folks in Hawaii have done similarly. And so helping folks understand and understanding what the concerns and needs are of the population, I think, is a really important first step. Other things that we can do across systems is to think through what else are we doing for vaccination efforts. Are we having, a community back to school event where vaccination might be a part of it, making sure that HPV vaccination is really a part of that. Exploring opportunities to help young people catch up. So if they missed their 11 to 12-year-old window, that's okay. We will take care of you at 14 or 15 or 16 or wherever you are, but just to make sure that they've had a chance to ask questions and hopefully to receive the vaccine. From a quality improvement standpoint, several of the examples that I give here on this slide are kind of clinic or adjacent to the clinic that we could help the service delivery for HPV vaccine. And this can be dosing reminders. So is there a way to have the electronic medical record send a message to a parent? Or could we get some sort of app or a reminder in our calendar on our phone that the next dose of HPV vaccination is due? Immunization registries, I live in Georgia and we have a great registry program, and that's how my clinic has really helped young people catch up if they haven't received the full vaccine, because all vaccines that are given in the state are in the Georgia registry. And so I can just look with every team that I have and, identify folks who maybe need their last dose and then can complete the series for them at the time. And then the other thing here that I mentioned earlier is that Vaccines for Children is a program that does cover the cost for this, because the cost out of pocket can be. This is a list of important resources that I hope you will enjoy. The CDC has an amazing HPV vaccination partner toolkit. Like it's awesome. It is useful for clinicians. It is useful for parents. They have a specific whole section on partners and engaging across different sectors, not only with how to engage, but pragmatic ideas about what you can do. That's the link that I have here on this slide that's called What Can We Do? It's really impressive if you are in a setting where you have a website that is yours, that you have control over. They actually have this content syndication tool where you can just go and select content about HPV vaccination that you would like to have on your website, and then they'll just keep it updated for you, right? Like if they come up with a new video directed towards parents, that will automatically appear on your website as well, obviously until you don't want that to happen. But there are an enormous amount of tools on their website. There are posters that you can order, other types of information sheets and materials that you can order or download that's super helpful. The American Academy of Pediatrics has an HPV Champion Toolkit that's also worth a look. That's particularly for those who are in clinical settings. Again, speaking to some of those quality improvement initiatives that I spoke about earlier. And the American Cancer Society has a good number of similar types of patient and community-based education in their vaccination clearinghouse. And with the American Cancer Society in our minds, I want to just bring up this quote from Richard Wender, who's the Chief Cancer Control Officer, which sounds like just a lofty and awesome title, huge job, who believes this. They launched a campaign this summer to increase HPV vaccination, and he says, if we can achieve sustained 80% HPV vaccination in preteen boys and girls, combined with continued screening and treatment for precancers of the cervix, we could see the elimination of cervical cancer in the U.S. within 40 years. No cancer in the U.S. has ever been eliminated as of yet, but we believe it's a real possibility. So I leave you with that as some inspiration. Thank you so much for your time and attention, and I'm happy to take any questions.
Thank you. So as previously noted, the requested resources and the resources discussed in Dr. Kottke's presentation are available for download, and today's webinar presentation is also available for download. If you have any questions for Dr. Kottke, please feel free to submit them in the presenter Q&A pod. So Dr. Kottke, I will start with the questions. So let's address the elephant in the room. What do you say to the
Spectacular.
anti-vaccination parents?
So if I have a parent who is completely against any type of vaccination, um, I generally ask a lot of questions. You know, somebody who's vehemently against a vaccination, I may not be able to change their mind, truth be told. Particularly that's become such a contentious issue. I continue to state my medical opinion, and my medical opinion is that vaccines save lives, vaccines are safe, and I recommend them. And I don't waver on those. Like I believe that wholly and 100%. And so if a parent has concerns, I want to find out what their concerns are so then I can present data. And data is the best thing that I have. And then, you know, stories of folks that, I mean, I've only ever seen success and safety of vaccines. So I try to present that and try to allay any fears that they may have. And then also leave the door open for questions. You know, ask permission to say, you know, is it okay if we talk about the things that are concerning you? Is it all right if can I just give you this information and try to share high quality evidence and high quality information so that, you know, they can take something home with them and think about it. And then I invite us to continue to have that conversation going forward so that, you know, hopefully maybe our conversation, something about how we discuss, maybe they'll go home and think and talk to somebody or read whatever information we've given them. And maybe the next time they come back in, we can talk about it
Thank you.
again.
Next question.
So that's my approach.
In a previous conversation, you and I were discussing destigmatizing versus normalizing HPV vaccination. Can you please explain to the audience why you would prefer the term normalizing as opposed to destigmatizing?
Yeah. Well, I think that kind of as one of the strategies for providers, I don't want to. I think that the way that we're going to be successful is this is one of the vaccines that we recommend. It's interesting to me, and I think it has to do with how it rolled out just temporally, right? Like this is the last vaccine that was kind of added on to the schedule at that time, and people, of course, had a lot of questions about it. But one of the things that I think is interesting is that we don't talk about the mechanisms of action. You know, like clearly the whole idea of stigma is that folks are concerned about this being sexually transmitted, and that we struggle with our society of talking about sex in a way that is normal. And so, but we don't actually talk about any other vaccine and how the infection is transmitted. And I liken it to someone who is traveling and you go and get, you know, all your shots to go to, you know, your wonderful destination and realize that the majority of the shots that you're getting, or a good portion of the shots that you're getting, are because of fecal transmission of an infection. And so I think we have to focus on what's really at the heart of the matter. And the heart of the matter is that we all want the same things. We all want our young people to be safe and healthy. And we have been given this amazing gift of something that can prevent cancer. We don't have that anywhere else. And so it is a very normal thing in my mind to say, we all want to prevent cancer, right? Like, and here we go. So, so I think that framing for me resonates. Others may want to frame it differently, and I think
so we have a question here from Elizabeth. Well. Elizabeth notes that the FDA recently approved Gardasil 9 for ages 27 through 45. She asks, is this a different dose?
It is not. Thank you. That's a great question. So this is the same dose, and somebody who followed that recommendation would require the 3-dose series. So 0, like you get your first shot, your next shot 2 months later, final shot 6 months later. The Advisory Council on Immunization Practices is due to kind of talk about that at their next meeting. So I think we'll be hearing over the next few months if they approve it and it makes it onto the schedule, which would kind of translate into probably having insurance.
Our next question is from Sandra. She would like to know, why is HPV vaccination recommended for people up to 45 years old?
So, you know, we showed the prevalence slide, in one of those earlier slides, and really know that the biggest time when folks have the infection is in their early life, like 15 to 25 is going to be that peak incidence. With that said, we know that the possibility to acquire HPV infection continues throughout your life. And just to acknowledge the variability of life paths that folks have, and that there may be people who are having changes in life that may ultimately increase their likelihood of acquiring an HPV infection later in life. So change to their marital status, loss of a spouse, those kinds of things. If somebody is having new sexual partners, it's possible that they could have a new HPV infection later in life. And for those of us who are, are old or were older than 11 to 12 in 2006 when this first came out, it also does give folks an opportunity to, if they are in that younger age where they're not yet in a stable relationship, it also might be a good option
Thank
for
you.
them.
Tracy writes that most of her population is over the age of 25, but she feels that the vaccination is a good opportunity to prevent cervical cancer. Her question is, how can she find out if their insurance will cover the vaccine?
Such a great question. Such a great question, and such a there's no easy answer. Truth be told, that would be kind of you'd have to have someone in your office call and just, or have the patient call and get confirmation on it.
Thank you. Our next question is
But I
from
know of
Melissa.
no easy way.
She would like to know if you had a budget to do one large-scale, big impact project to promote HPV vaccination, on what would you focus?
I think that engaging communities and families is the place where we could use more traction. And engaging them as a wellness and prevention focus. I feel like the medical community is working and is generally aligned in trying to get there, and I feel like they will probably get there. They'll get there. But I'm not sure that the same is true of our families and communities. And so I think really engaging people in addressing individual concerns and highlighting motivations, that would probably be where I would focus my energies.
Good question. Thanks. So our next question is from Richard, and he would like to know, from your experience, what is the best approach to engage African American communities around HPV vaccination?
Yeah, so I think that's a wonderful question. And, I live in Atlanta, and a couple of years ago, along with a nursing colleague of mine, one of the things that we did is we were actually invited to a health fair that was done with a coalition, for lack of a better term, of many churches and faith-based organizations in our town. And that was very interesting, and I think enormously helpful to understand some of the priorities of the community that we serve, and to help concretely addressing some of the there was at the time, and I hope that we've made some strides on this, but there was some misinformation and misunderstanding, confusion sometimes of what HPV was and what it wasn't. And so having that dialogue, I think, was critical and has really helped us frame some of our conversations. But I don't think there's any quick answer to that. I mean, I think going to the community, asking questions, and listening are going to be important in all communities, truth be told. And then in my clinical setting, I do some of the things that we talk about, trying to make sure that everybody who comes into my clinic has either completed the vaccine or is offered the vaccine to completion, sharing information and framing it as
Thank you. Our next
cancer prevention.
Question is from Amanda. And Amanda would like to know, how can community-based organizations partner with hospital groups or a clinic in order to increase vaccination efficacy?
Yeah, that's a great question. I think that there's probably no limit to the number of strategies. I will refer you back to the CDC's Engage toolkit because it does give some concrete recommendations and ideas about who you can connect with, and not just hospitals, but also smaller clinics. Our federally qualified health centers, our Title X clinics, our local departments of public health. Many of them are doing similar activities. So to even just have a listening session across the different agencies for what folks are doing, I think the opportunities for synergy become pretty obvious once we understand what the people across the street are doing in the area or could do in the area.
Our next question is centered around advocacy. What is your advice for a person who's interested in impacting HPV legislation at the state level?
Good question. There are some states that have different approaches with regards to making the vaccine available outside of vaccines for children, or maybe in addition to vaccines for children. There are some states that, this might not be at the state level, it might be lower than that, maybe at the school district level, that add HPV vaccination to the necessary immunizations required for entrance into school, which is sometimes a motivator for families. Those are some ideas. Just make any advocacy that supports people to have access to health care can help support having access to human papillomavirus vaccination. So expansion of Medicaid, things that support, so anything that supports providers in rural settings, those kinds of things I think have multiple benefits, this being one of them.
Thank you. Jill would like to know, do you consider raising the health IQ of the patient population through storytelling to be an effective method in HPV vaccination education?
I love storytelling. I can't speak to it in this particular setting, but I think that stories are incredibly powerful. And so, there are some social media endeavors that I didn't mention in the talk that have started to go down this path. I think there's a Show Your Love campaign, which was telling the story of folks who had been affected by HPV-related diseases. So yeah, I think that is enormously
Our next question
powerful.
is in regard to oropharyngeal cancers. Are you familiar with any research or data which points to the effectiveness of HPV vaccination in reducing oropharyngeal cancers?
Yeah, the data connecting them are early so far. We have good data that show that HPV vaccination impacts HPV infection in the oropharynx. But the data that would take it that next step to say HPV infection to HPV-related cancers, we don't have a direct correlation. But what we do know, and I didn't tell you this because I sometimes skip things, I have the percentage. So of oropharyngeal cancers, we do know that, from doing our pathology assessments, 70% of oropharyngeal cancers are caused by strains of HPV. So I think the dots will eventually be connected, and it makes logical sense that they would be connected, but those data are still kind of a work in progress.
Excellent. Our next question is from, and please forgive me if I butcher your name, our next question is from Armina. And this webinar attendee would like to know, in the state of California, for example, there is a fund from a private foundation to impact HPV vaccination rates and cervical cancer screening. The webinar attendee would like to know, what type of organizations should the foundation partner with to have the largest impact?
That's a great question. So I mean, you could almost partner with anybody. You know, what you need is partners who are enthusiastic about it. So I could see perfect partnership with obviously clinicians and educators and community-based organizations that are focused on adolescent health and wellness, but are also focused with cancer prevention, that are potentially also those that are at the intersection of sexual health or sexual and gender minority health, so LGBTQ populations. I think that faith-based organizations, um, yeah, any of them. We've been trying to connect with actually college-aged people to do catch-up vaccination for those who have missed it in the past. But yeah, I think just about anybody might be a great partner.
Okay,
Just
well, we
the kind of the
are
local flavor will
unfortunately out of
determine that.
time. So, Dr. Kottke, do you have any closing thoughts for our webinar attendees?
No, I don't think so, but I'm so grateful for everybody who spent some time together today, and I've loved your questions. I think they're just great, and I'm excited to join you guys all over the airwaves
Thank you,
in
Dr.
this work.
Kottke, for
So
an
thank you all for
informative and
what you do.
engaging presentation. And for the webinar attendees, we thank you for attending today's webinar, and we invite you to complete the series. We have 3 parts remaining in our Prevention Works series. You can access the registration links by clicking on any of the links that say register, and these links are also available in the presentation. Again, on behalf of the Morehouse School of Medicine Prevention Research Center, we thank you for attending part 2 of our Prevention Works webinar series. And you can connect with us via social media using hashtag PreventionWorks.